Fertilization Academy with myself, Dr. Greg Jones, and I'm excited to bring back Dr. Franck Kacou. I did it again, Dr. Franck Kacou. I like saying it, man. I dig it, man. It's
all
cool,
good.
Man. I know. It's like Franck from France. You can't be. How do you forget that? How do we forget that? And so, I was pleased to meet Dr. Kacou, Franck, at a recent conference, a Peptide World Conference in Vegas. And we started talking a little bit about what he works with in the compound pharmacy world. And we started talking about sexual health, peptides, and peptides in general. Again, random bar talk, but hey, man, that's what docs and pharmacists do. And, and I was like, hey, man, I really want to bring you on the podcast to talk more about erectile dysfunction and different ways to treat it and how to identify it. So if you were not here for part one, Franck is the owner of Progress Pharmacy and a co-founder of Nubioage Medical out in, you guys are in St. Petersburg, Florida, or?
No, we're in West Palm.
West Palm
Beach. Yes, sir.
Yep. West Palm Beach, Florida. And Franck is a compound pharmacist. He's a reformed commercial pharmacist and works in compound pharmacy now and really specializes in developing innovative. Sorry, let me do that again. And he really specializes in, oh my God, Dr. Jones, okay. There you go again. So Franck specializes in developing innovative and new pharmaceutical compounds used by practitioners in the integrative medicine world and beyond, has a passion for cellular medicine and compounding new and innovative products. And we're excited to have you back, man. So welcome to part two.
Love to be here. I'm so glad I'm here. Feel blessed to be here. Thanks for having me again.
Thank you. Thank you. So for those who missed part one, you can always go to our YouTube channel or the iTunes and Spotify, wherever you listen at, and review that. But what we talked about in part one was identifying the root causes and conditions that lead to erectile dysfunction. And one of our highlights is getting into part two is getting that recognition that erectile dysfunction is not a disease, it's a symptom. It is a sequelae, or as we like to say, it's caused by something else, or it's a effect of something else, if you want to look at it that way. So that being said, our number one thing as practitioners is identifying the root cause, like what's causing this, why is this there? And once we do that, we can get to some of the treatment things. So we talked a little bit before, like, me being the naturopathic doctor here on set, I'll start with some of the things that we always look at first, and then we're going to transition into Franck's specialty is how do we treat it and what are some novel ways to approach it, right? So that being said, if we understand that many of the causes for erectile dysfunction are vascular in nature or diet in nature, then that's where we go first. And this is, in my opinion, anyone that's coming in the office complaining of that, right? So what are you eating? So for me, I'm looking at it like this. Okay, number one, are you happy? Are you stressed out, right? Because again, that's the psychological piece of it, right? Number two, what are you eating? Let's do a diet diary. Like what did you eat yesterday? What did you eat over the weekend, right? How much are you drinking? If you are drinking, if you're using cannabis, I ain't judging. Very awesome for many conditions, but how often are you doing it? And how much are you doing in a setting, right? So we identify those root causes. That's our foundation, right? So do you take vitamin D? Do you take any zinc? You have symptoms of these do you have symptoms of these compounds being low? So that being said, the foundation in most of our cases are going to be diet, psychological, exercise, right? So once we get that, then we get into what can we do about it. And this is where I'm excited, man, for you to start talking here. So let's talk about some of the compounds that will address correcting erectile dysfunction while we are correcting the root cause.
Yes, sir. Well, there's a lot of them, and that's the beauty of it, So we got a lot of compounds in the toolbox to get it done, So I like to, the first class, and I don't go into details about the chemical name or anything like that, but I want to refer them as P5 inhibitors. That's your Cialis, your Viagra, your Levitra. People usually know those guys right there. They've been around for a while. They're your go-to when it comes down to ED. Just to kind of help everybody understand that a little bit. They all work the same, then they get tweaked a little bit about one, duration of action and onset of action. All it is timing. When do you take them? And unfortunately, a lot of times people don't really explain that to people. When do you take those steps, right? Let's start with Viagra, right? Viagra is the number one out there. In the case of Viagra, it actually works you start to work 30 minutes after you take it, all right? Assuming you don't have a full meal in your stomach. So if you take it on an empty stomach, you'll work on point after 30 minutes. But most people, I mean, let's be honest, you usually have some food in your stomach, so it's not gonna work right away. Peak of action is about 2 hours after you took it. So you got to time it right when you actually have the same, when you actually have ED, you have a problem, you want to try to use this. So Viagra will say, so let's just go back again. So Viagra, 30 minutes to get started, 2 hours to peak. When you move to something like vardenafil, which is Levitra, it works a little faster. So peak action of Levitra is 30 minutes. So you have a short window of time, boom, 30 minutes, I'll start working, assuming you have an empty stomach, all right? And you'll stop working faster than Viagra, for example, right? And then you have good old Cialis with Battlefield, which is, remember, the 3-day, it's called a 3-day drug, it's a weekend drug, where you take it and it's not going to start working till 12 hours. Really, the peak will be 12 hours after you take it, and it'll last up to 48 hours, right? That's what we call it, the weekend drug. So those are all the options that you have out there. So what we do in the compounding world is we try to make this drug as bioavailable as possible for the patient, because when you have a full stomach, it becomes problematic, right? So we have to figure out a way to deliver the drug into your systemic, into your system, really, as fast as possible. So we like to compound it and put in what we call troches, or just simple candies that you put on your tongue and they dissolve there nicely. And the drug, or the API, like to call it, will be faster, more bioavailable to you, which in turn will lead to hopefully faster results, right? So when you take a pill, a lot of the time the pill has to go through your stomach. It gets killed over there and there by your all your enzyme, your stomach enzyme. From there, it's gonna go down to your intestine, where there's a little more work in there, not a very friendly environment. And then from there, it gets distributed. Assuming that you're really, assuming you have a good gut health, then you have a really good absorption of the drug. So 100% will go down to 10% down in your stomach. So if you do it underneath your tongue, it's usually better absorption. We call it better bioavailability. So in the compounding world, we like to use a troche, or a candy kind of thing that you'll take to make the drug more bioavailable. So that's the first step. Now, within that world of P5 inhibitors, we like to mix and match, right? Because nobody does that really often. If you think about it, yes, you can take Cialis, which is a long-acting, and mix that with your vardenafil, which is a short-acting. So you get the best of both worlds in a way, right? So as compounders, we love to do things like this. So this is a way of innovation, right? So you're like, all right, doc, are you comfortable with this? Yes, let's do it. So you put a nice Cialis in there, again, in a troche form, and then you add a vardenafil. So you cover, right? So you got, if you don't know what you're dealing with, so you get vardenafil, working in 30 minutes, and then you cover for 2-3 days with a tadalafil in it. So it works the same. It'll be like a 20 milligram Cialis, and you mix that with like a 22 milligrams of vardenafil, and you can do the same thing between Cialis and Viagra, right? So if you like Viagra better, we'll do the same thing. We'll mix the tadalafil, which is your Cialis, your long acting, and then you have your Viagra in there as well, which is a short acting, together. So that's one of the things that we do to kind of help the patient a little bit, because timing is the problem, right? Number one issue. So yeah.
So one thing I want to ask you about is, because you mentioned with the troche, the bioavailability is increased. Does that change the timing? So like you were saying about Cialis having that 12-hour window for when you take it, for when it's optimized, so to speak. Does that change when you're doing the troche?
It does not. It doesn't. It actually optimize that timing, because a lot of the studies are done in vitro. So when you do those studies, the patient's perfect. So they give you those numbers in the perfect patient, right? Is the patient is literally on an empty stomach, they're optimized, no aligning conditions, everything is great, everything is beautiful. So they give you that number as 30 minutes on an ideal patient, right? Most of the time, 90% of the time, most patients are not ideal, or they're not optimized at that level. They usually, when at dinner, they invited their wives or spouse out, they had a nice steak or fish or whatever it is, or they're stressed out, they have GI issues, you know, there's a lot of factors involved. To get, so we do with the troche, we're actually optimizing that number. We're getting as close as possible to that 30 minutes. That's the difference, really.
That's
really an increase in onset of action, but we are more on point with where we need to be.
Just make sure, because you kind of broke up a little bit. You're just confirm, because there was a little snag in the stream right there. You're saying that it does not change the onset of action. Is that?
It optimized it, exactly.
Optimized it, okay.
More, yep, it makes you more on point to that number. Okay. So if the literature is saying 30 minutes, but we'll get you as close to that 30 minutes as possible, because it's working fast.
Gotcha. Yeah. So it's not like I'm going to do a troche, let's say with the tadalafil, it's like, okay, 12 hours. All right, I'm going to take it now. And okay, because it's troche, it's going to be, I'm ready in 2 hours. So just make sure that people understand, like, no, it's still, you know, just closer to what the optimal timing is. So I think that's an important thing to know, because what'll happen is someone will take the troche and the timing's off, and they'll be like, oh man, this didn't work. Or didn't work the way I was expecting it to, because it's a timing issue, not so much a medication issue. That's super important.
That's exactly right. Timing is a key. Again, that's the role of the clinician or the provider, to actually sit down and explain that to the patient. You know, most of the time you're taking the right time. You know, just see it as a, you know, as an airplane. Like I like to use this analogy, right? Where when you take off, you put power, right? It takes forever to kick in, right? You start slow, and then after 35 seconds or so, then you're really feeling the airplane going, right? It's the same thing with the Cialis and the Viagra. You know, if you take it and you're expecting results right away, it's not going to happen. It takes a little bit of time to happen. So you got to plan it right. You know, and that's the number one reason why people kind of usually like are not comfortable. Like, oh well, give me the erection like when I wasn't ready. You got to understand when they work. You know, so if you want consistency and you're looking for more compliance, the troche is a good option.
Got it. I appreciate that. And so now that's one option right there. So after we look at the P5 inhibitors, what's the next class of either medications or peptides or compounds to look at?
Yes, sir. So, you know, another one that people love to use right now, they're called Trimix or Bimix. So they're really vasodilator. You know, I'm not going to go into details about the chemical names. They are. They're vasodilator. And what they do is they kind of help blood flow into the penis area, right? Because, you know, you failed, usually this is after you failed your P5, right? So you failed Cialis, you failed Viagra, you failed all those guys. Like, man, it's not working as well as it used to be. What's next? Doc will be like, all right, man, this is not good. So let's go into like actually mechanically increase the size of the blood vessels in there, to, you know, to allow the blood flow, whatever is left, to get in there. So we use those Trimix, Bimix type of products. And what they do, again, I just described it. The application, how you use them is what's problematic, and this is why we innovate a little bit. So Trimix is designed to be injected into the penis, right? As you can tell, compliance is not a really good thing with the Trimix, because most people are not comfortable injecting, right? They're not comfortable injecting. So what do? It does work really well. It usually creates an erection after, you know, 30 minutes. It's usually pretty much a guarantee most of the time. To either keep it in the stable in the fridge, and you have to inject a needle inside the penis. So those are, you know, the reason why we do it. What we've done with this a little bit more, just to kind of increase compliance again, is we just formulate a cream. So we do the same thing in the format, where we do the same ingredients, usually phentolamine, papaverine, Alprostil. So we use those three products and we put them in a very lipophilic base. You know, we different base that we like to utilize that will increase the absorption of the drug or API within, within the skin tissue, right? So you have the drug being transferred from one area, goes through the skin, and goes to the other area. So we put in a cream format, so people utilize that in the cream instead of doing the injection. It's not a guarantee again, but it's less messy, and it's something that another tool to give to people to kind of try. Another thing that we do as well is this different, same thing, the Trimix and Bimix products. We will do it as a erectile gel. Erectile gel is interesting because if you don't like needles, we actually will dispense that in a very small syringe, 0.3 ml, 0.2.5 ml, like oral syringe. The only problem with that, it does work as well as the injection, but you do have to apply that gel inside the urethra. So it cannot be, sometimes it's not very comfortable, but again, when you failed a lot of options and you need to go to a different option, usually people are willing to try it at least, but that will work and create an erection in about 30 minutes. So that's another class of product that we have out there that can help as well. But when you think about all those drugs, you got to start thinking about what they're doing, their role really. They're all kind of working your hypothalamus, because it's the way to really send that signal down to get you the erection, right? So with that being said, there's other drugs called, DA or dopamine agonist that also now developed to kind of help with this. One is called Apomorphine. I don't know if you heard about that one.
Yeah.
All right, so we like to utilize that quite a bit. There's a lot of solid studies out there showing the role of this product at creating or sending signals, very good signals to create, erections. And so they work differently, right? It's not really the mechanic in the blood vessel, but they work in kind of in your brain. If you think about it, they work in your brain to send a signal downstream to create an erection. So it's a different approach, right? To the same goal. So here's another tool here to utilize. We use it 6 milligrams, we use it as a 4 milligrams, we use it at 8 milligrams. Again, the studies on this were also done as a troche or a candy, I like to call it candy format for quicker absorption. So that's another option there, right? So what I'm doing with this, for example, right, I'll start thinking outside the box again. So here we have another tool. Let's try to utilize that and start creating something totally different here. So we can use this I call it DA, which is dopamine agonist here as an apomorphine. Why don't we link that with a P5 right there? So let's do apomorphine, tadalafil mixed together. There's nothing wrong with it. We start slow, we start low, and we go up as needed. But again, that's a very good way of combining different type of drugs that work. One that works in your brain, and then one that works more on the mechanical side at the blood vessel level specifically. That's another way to do this. Yeah, absolutely. We can keep going. There's so many more drugs. You stop me.
Yeah, no. It's good, and it's good to know because there's options, right? Because there are some patients who don't like sildenafil or the Viagra because they tend to get the congestion piece of it, or headaches sometimes. Sometimes we get that with Cialis as well. And sometimes, to be honest with you, some people, they just don't work. They just don't get the effects. I know. And I'm seeing that a lot. Yeah, especially, when I'm seeing clinically, especially if they have vascular issues, especially if the vascular issues are there, because it's like, that's what this is trying to resolve, but sometimes it's just not enough. And so we have to look a different pathway, that can do with that as well. So what's interesting is that this is something, as we're transitioning from the medications, just kind of looking at other options, getting back to outside of the box here, is that there have been a lot of talks out there on what peptides can be done to help resolve or treat erectile dysfunction. And so I know the main one that, has been out a little bit longer, I've been hearing about it for the last few years, is the PT-141. And so I definitely want to talk about that. And also the Melanotan II, are kind of like the big two, but if there are others that you kind of seen clinically that potentially have that effect, definitely want to hear more about that as well.
Yeah, for sure. For sure. There are definitely a few ones out there, and I'm going to throw one at you that you probably never heard of before at the end there. That's been showing some, excuse me, some pretty good, interesting results. But yeah, peptides are great tools, right? Peptide, long-chain amino acids, safe and effective way, signaling molecules to help you fight and treat ED. Absolutely, right? So most of the physicians out there don't know much about peptides. They probably never even heard of peptides. But here's another tool in your toolbox to start utilizing as a clinician, or even as a patient, to start looking into, to add on to everything else, or to try as a last option before going into something else like surgery or waves therapy. The number one that you talked about there is PT141. So it's by far the number one peptide utilized out there to help treat ED. The thing about PT141 that we kind of like is that it does help man and woman, right? Because it works in the brain again, right? We talked about that. The cell signaling event is happening in your, there's a cascade event happening in both men and women that will lead to better outcomes in sexual desire, for example, and in man, better outcome when it comes to erectile dysfunction. So your ability to keep an erection. It's well documented out there, but that's a very good option. So PT141 comes into two different options. Again, there's a sub-Q injectable that we use. Doesn't have to be injected in the penis, but it's something that you have to inject in the Q. So it can be in your stomach area, it can be in your thigh area, whatever it is. So that's one option. The second option on the PT141 is something that we also developed here, is a nasal spray, right? We think about nasal spray, nose, right there next to your brain. This is one of the best way to get systemic absorption is through your nose. If you forget something I say today is, don't forget what I'm about to say. More drugs are about to get on the market when it comes out to nasal spray. Nasal spray is probably the number one of the best secret delivery system in the world. But keep that in mind. But PT141 nasal spray is another option as well. So timing becomes problematic with those things. They have less side effect than Melanotan that we'll talk about here in a minute. So it's my number one option when I talk to a prescriber about PT141. You have less side effects and an easier compliance issue. So one injection, you can inject it as needed 1 to 3 times a week. Actually, it works so well that people have to be very careful. 41. Most pharmacies out there will compound the nasal spray, as a 0.5 milligrams. We at Pharmacy and Nubioage, we actually use even a higher dose, which is easier for the patient to actually one spray instead of multiple sprays of PT141. Will do the trick, because there's the main side effect of it, if you have a side effect, might be nausea or headache. There's always side effect to everything, but at least it's an easier one to deal with compared to what I'm about to talk about, which is Melanotan. Melanotan is a different type of peptide. They're pro-hormones. It's something that people don't really understand really well, but we used to call them the best libido boosters out there. But when it comes to sexual stimulation, it works extremely well. Without going into too much detail, there's something called MSH, which is an alpha melanocyte stimulating hormone, MSH, which is very important at modulating in a way. And Melanotan will work will work very similar to MSH. Melanotan II does promote sexual desire, does promote better erection. The only problem with Melanotan is that the side effect is pretty severe if he's not pretty well. So originally it was utilized for people to actually start tanning, right? So if you want to tan, you Melanotan to tan, right? So let's say you live up there and you want to get a nice tan. Those are wise, right? To actually get a tan during the winter. But they also discovered that, holy cow, this actually also works really well for sex, right? A lot of people using that, injecting weekly, do say that they have better sex. So it became all this option, started utilizing melanotan for sexual dysfunction in men and women. So those are two solid options there for ED when it comes to peptides. The last one I was going to talk to you about that people really haven't talked about yet, but it's something to think about, is tesofensine. I don't know if you know what tesofensine is. It's something that you actually utilize for, it's a peptide, the PO peptide. You actually utilize PO by mouth, utilize for weight loss. But tesofensine is interesting because it actually will work. Women will work on serotonin and norepinephrine. And the beauty of it is it'll help you stop eating, but at the same time, it'll increase your libido. So, which is interesting. So there's a lot of things happening about tesofensine. First of all, it's really hard to get, and we were actually trying to get it in stock for a patient. But here's another tool that doesn't have to be injected, doesn't have to be sprayed in your nose. It can be taken as a weight loss product, but having some really awesome side effect, which is going to be increasing sexual desire and ability to keep an erection longer. So those are 3 peptides that I usually recommend. They're my go-to.
Yeah.
PT141, melanotan, and now potentially tesofensine.
I read a paper, the tesofensine. I got a hold of some articles a little while back, and I remember reading about the weight loss benefits of it, but I didn't see the libido stimulating properties of it. So I definitely may revisit those papers and take a look. Couple things kind of circling back. I want to talk about PT141 for a second. Is that I don't know if you kind of mentioned that, and you may have, just if you did, just forgive me here, is that one of the side effects that I've had patients mention was nausea. Was a nausea piece of it as well. And so I've had some compound pharmacists actually add B6 to it to kind of prevent that. Now that nausea, do you feel like it's a more individual case? Is it like the higher the dose or the frequency of dose that kind of drives that nausea with the PT141?
It's the frequency of the dose for sure. What's happening is a lot of pharmacies will, by the way, I hope you can hear me all right there. A lot of pharmacies will will actually make strengths, 0.5 milligrams per spray. A spray system, excuse me, a spray system has usually 0.1 ml. So when you spray in your nose, it's a very small amount that goes in there. And unfortunately, a lot of the time that get lost. So you spray 1 milligram, you probably actually getting 0.1 milligram, right? Because you're losing so much. Not the full API is going to where it needs to go. So if you're starting low at 0.5 milligram, unfortunately, what's going to happen is you're not going to feel anything and you're going to start spraying a little more, right? So what's happening is the frequency of the sprays becomes problematic because people will start spraying or trying to utilize the product more than they're supposed to, just to kind of get that feel. That will cause that side effect you just described. So what we like to do is we like to have a higher concentration from the get-go, 2.5 milligrams per spray, put it into an awesome base. We call it Mucilox, which got a very, very good stick to the mucus inside the nose for this transfer of drug across the wall. So when you put that, and that's another question, it's another thing for patient out there, when they're talking to the pharmacist or for prescribers, talking to the pharmacist, always ask them, what kind of base are you using? Like, what is it? Are you mixing this PT141 in water? Are you mixing that in something else? Because if you're mixing it in water, what's going to happen to water when you spray water in your nose? It's going to go down, right? It's not going to stick to the lining. So the drug, but think about the drug. If you put a drug on your skin, we put water on your skin, what's going to happen to the water? It's not going to stay there and get absorbed. It's just going to drip somewhere, right? Make sure you put it in a base that will actually stick to the lining, which will allow for the drug to actually penetrate and go from one side to the other. That's when you're actually getting, actually outcomes, results. Base is very important. We in our 2.5 milligram in Eucalox base, put it out there, it sticks really well, just one spray, decreases your less side effects, and you're good to go.
Awesome. And then it's funny, you're talking about the Melanotan II. When I was doing some research on it, it talked about, it was a tanning, because of the MSH stimulation, right? And that what the erectile function piece was like an unintended side effect. Yep. And, I just thought to myself, like, man, that'd be a interesting, you're waiting the tanning and then just like, oh, this is happening. And so you're just like, wait a minute here. I jokingly said on one of my Instagram posts, this is the world's worst tanning salon, because like, what's happening here, right? It's unexpected. Now,
dose too, because it's really hard to dose. That's the problem with this thing too. Yeah. But it's a great tool. It's a great peptide to have. It's a great toolbox.
Yeah, for sure. And then with the PT141, have you seen any difference in the efficacy with male patients versus female patients?
If you don't mind repeating that question, I lost you there for a second.
Yeah, no worries. Do you find it to be more effective with your female patients or male patients? I know it's going to be effective in both, but do you see that it can be more effective in females versus male? Because that's something I've kind of seen. It still works, but I think I get a better response in my female patients.
Anything about the PT141?
Yeah.
All right. I can tell right now, it's dose dependent.
Mm-hmm. Gotcha.
Absolutely, dose dependent. And you also got to think about again, ladies are so complicated. There's so many more things affecting their mood, their ability to be engaged in sexual activities, depending on a lot of things, or hormones and things like. So the guys is still different, but what I've seen is this dose dependency. Go ahead. You had a question? You good?
Oh, no, it's good. It's a quick call. I think our signal is kind of breaking up. I don't know if it's on your end or my end, but like for me, like it's quick, but you're getting like little glitches, and I don't know if you're seeing glitches on my end. So it glitched.
Yes, I am seeing something.
So yeah, hopefully it'll be cleared up in the recording here.
My Wi-Fi is like the bomb.
Yeah, I know. So what we'll do is we'll clip and we'll say, hey, we're going to say that we'll start from where you said that it's dose dependent.
Cool. So a lot of the times the lower dose will work really well for the ladies. But if you give the same dose to a guy, it's not going to work. They really need 2 or 3 times the dose that you give in the woman to get any type of outcome, if there are any. But the higher dose is where you want to be. Absolutely, there's no question about that.
Sure, awesome. I appreciate you getting that cleared up for us. So especially all the clinicians out there who are watching this and looking for little bit of recommendations there on how to dose between our male and female patients. So, man, this has been exciting to say the least, man. This has been great. Lots of options out there. And so this is the cool part about this medicine, about cellular medicine, about peptide therapy, about working with compound pharmacists, is that being able to know your patient, what's going on, and what's going to work best for them. And so we have all these options that we can bring together. Because I know there are some compound pharmacies out there, and I'm not sure you guys do it, that can do the PT141 with the tadalafil or sildenafil. I mean, it's just, you mentioned the Bimix, Trimix. There's so many options out there, and that's what makes this exciting. and not just in sexual health and erectile function, but just general, cases in general, I'll say it again. And that's what makes that so exciting, not just in sexual health and erectile dysfunction, but cases across the board, because we can really individualize our treatment for our patients using this medicine. That's awesome, man. Like I am excited to be part of this movement here. So
absolutely,
yeah.
Absolutely. It's just those tools that you have at your disposition are just so many of them. And it's just, as a clinician, be able to recognize the first, you have the tools. The second of all, you have to actually identify where the problems are. You can't just give Cialis and expect results. It's not going to happen. It's a full approach here. Like you said, nutrition, exercising, and then yes, some medications here and there. But it's a full level approach. Are you happy? Are you depressed? Are you stressed? Viagra is not going to cure that. It's not going to take care of it. So you got to start from the top and then find your way down to get that result. So that's the difference between a doc like you and a lot of docs out there.
Yeah. And you mentioned that happy piece here. This is so, I think about this is sometimes I'll have patients come in and be like, well, potentially some erectile dysfunction issues. And you ask, well, how many hours a day do you work? Especially if they're in like a high level position. It's like, oh, I have 14-hour days. Okay. And are you tired? Like, oh man, I'm exhausted. I'm working so much. I got the kids, I got this, and this. And I'm like, I don't think you have ED, man. I think you're just tired. Like you're overworking yourself. That's stress and overwork. And so in those cases, sometimes, it may be looking at some of the mental emotional piece, supporting the adrenal glands, all these multifactorial pieces before we even jump into medications or peptides. So not forgetting that piece as well. So again, man, we can talk about this all day. And I think we kind of have, man. We kind of, this is exciting stuff, man, and very happy to bring you on
for
the
sure.
show. Yeah, it's been amazing.
For sure,
man.
absolutely. And the conversation needs to keep going. And the more people are more aware of what's out there, the better it is. So
indeed. So that being said, man, I'm gonna let you go ahead and enjoy the rest of that Florida fall out there and the great weather and all that good stuff, man. So before we go, in case people did not see part one, where can we find you?
Franck at Nubioage.com is the best way to get a hold of me. FRENCK at Nubioage.com. If you have any questions, just send me an email there. We'll get back to you. Or Instagram, Facebook, another way to do it. But I'd love to talk to people, answer questions whenever they have for me.
Exciting, man. Exciting stuff, man. So thanks again, Franck. I appreciate this, man. Oh, and all the contact information for Franck will be down in the show notes as well if you missed all of that. We're excited for you to listen to this episode, to watch this episode. If you have any questions, you contact myself or Franck, and we'll get back to you as soon as we can. And thanks again for listening, watching. Thanks again, Dr. Kacou. This has been great, man. Hope to have you back on the show soon.
Thanks for having me. It was a pleasure. Can't wait to get back.
Thanks, man.
Thank you.